Now, it's very important to identify the clinical features of a stroke as early as possible, because it may be possible to give the patient thrombolysis. So we know that most strokes are caused by thromboembolic pathology. There is a thrombosis, and emboli originate from that and spread off to occlude cerebral vessels. Now, thrombolysis will lyse or break down a thrombus. So in the acute situation, once a definitive diagnosis of a thromboembolic pathology has been identified, that is, in opposition to or as opposed to a hemorrhagic cause of the stroke, if it's a thromboembolic stroke, then in the acute care, thrombolysis can be considered. And the thrombolysis will break down the blood clot, allowing the blood to reperfuse the ischemic area of the brain, and will reduce infarct size and will greatly increase the prognosis. And of course, the earlier that is done, the better. So it's very similar to the situation in coronary care. If someone's got an acute coronary syndrome, and there's, for example, if they've got a STEMI, an ST elevation myocardial infarction, there is red blood clot, red thrombus in the coronary arteries, then we can give thrombolysis to break that down and reperfuse the infarcted area of myocardium. So it's very similar in stroke care. This can be done in stroke care once a definitive diagnosis of thromboembolic stroke has been made and once contraindications have been accounted for. But of course, just think if it was a hemorrhagic stroke, if the stroke was actually caused by bleeding, then in that case, the thrombolysis, the thrombolytic therapy, would dissolve the blood clot or any blood clot that had formed to reduce the hemorrhage, and the blood would just gush into the patient's brain. It would be an absolute contraindication and would kill them really quite quickly. So thrombolysis, good in thromboembolic stroke. Thrombolysis, absolutely contraindicated in hemorrhagic stroke. And in thrombolytic stroke, the earlier it can be given, obviously, the more benefit it's going to have. And especially in thromboembolic stroke, you don't want to give it after several hours anyway. There's going to be different protocols for different places, but the later you give it, if you're giving it hours later, firstly, you're not going to get any benefit. But secondly, the way I think about this is that if an area of brain has been infarcted for a period of time, that's going to involve the blood vessels as well, and there's a risk that the blood vessels can be deteriorated, and you can get what you call hemorrhagic transformation. So even without giving thrombolytic therapy, you can get hemorrhagic transformation in stroke. So what you have is an uncomplicated area of cerebral infarction. Then at some point after that, there can be bleeding into the area of cerebral infarction. It's a hemorrhagic transformation. And obviously thrombolysis, if it was given late, would make that more likely. So thrombolysis can be absolutely brilliant, but got to be given early. Got to make sure it's a thromboembolic stroke. So early diagnosis, very important. Now, it is normal to classify these cerebral ischemic events as a stroke or a transient ischemic attack. Now, classically, the differential diagnosis here is that a stroke is a neurological lesion with a vascular etiology which persists for more than 24 hours, whereas a transient ischemic attack is going to be a neurological deficit which resolves within 24 hours. Not a particularly good definition, but that's kind of the one that we're stuck with. So transient ischemic attacks are going to self-resolve within 24 hours. Now, a stroke in evolution is a stroke which is actually occurring at the time. So the clinical features of a stroke will probably develop or present after a few minutes, but then the stroke can go on developing for about maybe 6 hours after that. When the stroke's actually developing, that's called a stroke in evolution. So the thromboembolic event has occurred, but the pathology is working itself out. That's a stroke in evolution. And then when there's no longer any neurological degeneration as a result of the thromboembolic event, that would be called a completed stroke. A completed stroke. So a stroke will start off by being a stroke in evolution, and then after a period of hours it will be a completed stroke. So collecting history of how long the patient's had symptoms for is massively important because it has implications for thrombolytic therapy. We need to establish the last time when the patient had no neurological symptoms. And that tells us how long the stroke has been in evolution for, and that will inform us how appropriate and indicated thrombolytic therapy will or will not be. And as well as gaining history from the patient, gain history from whoever you can. Husbands, wives, sons, daughters, lodgers, workmates, anyone you can get hold of that can give you information about the patient's immediate past medical history. So in terms of specific clinical features, we've said there's focal neurological dysfunction of the brain. And headaches can precede neurological defects, but headaches seem to be more common in hemorrhagic stroke. A lot of patients who have thromboembolic strokes don't get headaches actually. But fitting can occur in the first few days after a cerebrovascular infarction. Now, fitting or seizure activity can be manifest as tonic-clonic fitting. It's what we used to call grand mal epilepsy or a grand mal type convulsion. So in a tonic-clonic fit, there'll be a tonic phase where the muscles go rigid, and then a clonic phase where the patient shakes. It's a shaking fit, and consciousness will be lost at the very onset of the tonic phase. So there can be tonic, clonic, and then after that there'll be a coma phase. The patient will be unconscious for a period of time. Now there can be fitting whenever the brain is insulted, whether it's a focal insult or a more global insult as might be caused by hypoxia. So up to a fifth of patients, according to some studies, can have seizure activity in the first days after a stroke has occurred. And a minority of patients can go on to get chronic fitting or chronic seizure activity after that, but thankfully most do not. So in a stroke there can be reduction in Glasgow Coma Scale, reduction in the level of consciousness. This is particularly true if the stroke is affecting the brainstem area, and also true if the stroke is large. But with smaller strokes, particularly if it's a lacunar type infarct affecting only a small area of the brain, then the level of consciousness can be uncompromised. It must be very frightening for the patients. They're completely awake, and yet they're aware of this acute neurological deficit developing. And one of the classic features of stroke, of course, is hemiplegia. Now, if you draw a line right down the middle of your forehead, down the middle of your nose, through the middle of your lips, all the way down through the middle of the body, when we're talking about hemi, that's what we mean. We mean one side of the body. So hemi is one half of the body. Plegia means paralysis. So a hemiplegia would be paralysis of one side of the body. Or there may be a hemiparesis. Again, one side of the body is being affected, but paresis means a weakness. So hemiplegia would be paralysis of one side of the body. Hemiparesis would be weakness of one side of the body. And there could be a monoparesis or a monoplegia as well, just affecting one limb or even one part of the limb. Depends on the area of the brain which is infarcted. So hemiplegia, hemiparesis, monoparesis, monoplegia, all possibilities. And nearly always this will be associated with hemisensory loss as well. So again, there is loss of sensation from one side of the body. Or there could be a monosensory loss. That's also possible, losing sensation from one arm or leg. But very often there's this hemisensory loss affecting one side of the body. As well as that, it's not uncommon for the patient to be confused. And also we want to talk to the patient about their vision. So for example, there can be a hemianopia where half of the visual fields are lost, or there can be a diplopia where there is double vision. Both of these and other visual defects can be features of stroke because of course the occipital lobes can be involved. Now aphasia would mean loss of speech altogether. Dysphasia would mean difficulty in speech. Now the speech centres are usually in the dominant hemisphere. So if someone's right-handed, that means they're left hemisphere dominant. So if a patient presented with right-sided neurological deficit, such as a right-sided hemiplegia, it's quite likely that they're going to have aphasia or dysphasia because it's the left-hand side of the brain that's been affected, and in the right-handed person, the speech centres are nearly always going to be in the left-hand side of the brain. If it's a right-handed person and they've got a left-sided hemiplegia and a left-sided hemisensory loss, that means it's the right side of the brain that's affected, and normally they won't be aphasic or dysphasic. And with these patients, it's not that they can't form the words, they actually can't work out what words to say. So you might have been in that situation at work, a patient's come in with a particular condition and you just can't bring the name of that condition to mind, or you can't remember the name of a piece of equipment. You kind of know what it is, but you just can't bring it to mind. It's like that for aphasic and dysphasic patients. They have a sensation of what they want to say, but they can't convert that into words. Very, very frustrating for these patients. And some patients can have receptive dysphasia, where they cannot understand the words that are said to them. Again, this must be very frightening. It's like you're talking to them in a foreign language. Other features include vertigo and dizziness, and dysarthria is another possible feature. Now, dysphasia is not knowing what words you want to say, but in dysarthria, the patient knows what words they want to say, but they find it difficult because they find it difficult to move their mouth and their lips and the tongue. The dysarthria is it's difficult to physically form the words. So dysphasia, they can't think of the words to say. Dysarthria, they find it physically difficult to form the words. And of course this can be associated with swallowing difficulties, resulting in possible aspiration. So patients are probably going to want to be investigated. There's going to be a full physical examination and history taking, of course. So we want the clinical history, we want the clinical picture, and it's possible that computerized tomography scanning or magnetic resonance imaging scanning will be carried out. And this is very important because these scans can differentiate between the hemorrhagic and the thromboembolic. Also, we want to see what the patient's heart's doing, so an electrocardiogram is a possibility. And we might consider cerebral angiography at some stage. And then differential diagnosis is important. What else could this be apart from a stroke? Because we don't want to miss strokes, and we certainly don't want to say things that aren't strokes are strokes. Now, the key differential diagnostic feature here is that the clinical features, the neurological deficits that develop when patients have strokes, develop quickly, typically over minutes. Whereas with a brain tumour or an abscess or a subdural hematoma, the clinical features can develop much more slowly. Or with demyelinating disease, like multiple sclerosis, again the clinical features are going to develop more slowly. Whereas with stroke, the features develop over a few minutes typically, so there's a faster onset. And another common confusion with stroke is Bell's palsy, where there is a peripheral nerve lesion probably affecting one side of the face. And with a Bell's palsy, the patient will be unable to lift their eyebrows, they won't be able to wrinkle their forehead, and they might not be able to close their eyes properly on the affected side. But whenever you can, get a neurologist to differentiate between a stroke and a Bell's palsy. But Bell's palsy can be quite frightening until the patient is reassured they haven't had a stroke. They've actually got a Bell's palsy caused by a peripheral nerve lesion. So, as always with our observation of clinical features, we want to observe the clinical features which are present, and we want to observe how they change, how they evolve with time, because all this gives us remarkably useful clinical information that can inform optimum patient management strategies. Patient management strategies. Patient management